All right, so you should see my screen here. Is that correct? You guys see the slides all right?
Yes.
Perfect. All right, well, then let's go ahead and get started. Just kind of by way of orientation, what we've kind of asked you to do, this is a cool picture of me, obviously, you see here. If you don't know already, there's a mute button down here at the bottom, and we just ask that you keep yourself muted. Unless you have a question, then you can unmute yourself and jump on in. And if you'd like to, go ahead and click on the chat button, which is down at the bottom, and that will allow you to ask questions kind of as we're going, and then we'll be able to get to those throughout because that question will be documented. And once you click that chat button, you'll see a pane like this kind of open up on the side. And then down here, I'll kind of zoom in a little bit. You'll see down here is the box of text where you can kind of chat or type in your question. Then you press enter and it will appear for everyone. Just make sure that it says to everyone and not to any one individual, but to everyone. And then obviously there's a dialog box that you put the information in. And for those of you who don't know, this is us. We're Preferred Physical Therapy. My name is Dr. Nick Hunter. And next to me here on this picture here is Alyssa. She's another PT. Hannah, another PT. And Jessica and Colton are both physical therapist's assistant. And then we have Christy in our admin team, as well as Julia. She started about a month ago. And Shelby is also on this call with us. So if you have anything specific, she's going to be helping me monitor the chat fields to make sure that all your questions are asked and that we're able to move through here pretty quickly. And I'm going to pull this mask off because I think it's going to help you guys hear me a little bit easier. And since I'm just talking to my computer, we'll be okay. All right. So again, my name is Dr. Nick Hunter. I'm a physical therapist, and I own and operate Preferred Physical Therapy, where we have helped hundreds of people aged 40 plus stay active and independent, live free from painkillers, and avoid surgery, even if they've had pain for years. I have written 8 ebooks on how to treat common injuries and hosted numerous webinars much like this, all in an effort to help educate the public on how to care for and maintain their bodies to live a life with joy, dignity, and without compromise. And again, this is us. This is who we serve, what we aim to do, and ultimately, we really are looking for ways that we can help people find joy in the journey, help them feel like we're a source of information to help encourage them to make better decisions about their health. So many people are trapped or feeling like they don't know who to go to or turn to for information that's has their best interest at heart. And so often I feel like I've had so many patients come to me saying that they felt either pushed or encouraged to do injections, pain pills, or even surgery, and they didn't feel comfortable, but also didn't feel like they had any other choice. And so the hope here is to help you feel encouraged and empowered to exercise those choices and know who to turn to for some resources in regards to how to do that. And so for you, you're either here because you or someone you love has or has had knee pain and is getting in the way of living the life that you want. I see a lot with difficulty sleeping and then in pain. And when you add those two up, we become irritable. We're no longer who we want to be in front of those that we love. It also can cause difficulty walking, which can eliminate or exclude us from being with friends and playing with grandkids. So we have FOMO, and FOMO is the fear of missing out. It's a new term that we're using these days. Apparently, I have 4 boys, and we hear that often enough. There's also some difficulty in how we manage ourselves, getting up from a chair or a toilet. We're maybe having difficulty with balance. So there's a fear of a loss of independence. This is one thing I talk to a lot of patients about, wanting to retain their mobility, be able to be at home, but ultimately not feel like they're a burden on their kids or their loved ones who they're around. They don't want to feel like they're making other people arrange their schedule or reserve only certain activities to invite them to. They don't want that feeling of being a burden, and so there's a bit of dignity that is apparent that is needing to be attended to and taken care of. And so this webinar is hopefully a way to help you make better decisions about your health and help you also see that there are options for you. Often we get people like yourself who come here and are wondering what can be done about knee pain. You have a family member, acquaintance, or doctor that said that ultimately you're going to need surgery and there's nothing that can be done. We just have to wait. Maybe you're in this limbo or this holding pattern that we think about in regards to what can be done about your knee, and that eventually only thing that's going to help is knee pain, but you're not a candidate yet. So what do you do between now and then? And so our goal is to help you know that there are still options that exist to get some relief now, get some long-term relief, maybe even avoid knee replacement, but ultimately help you live a life that you want to. We kind of already talked about some of these things, but ultimately we want you to feel like there are options, and we want to show you the model that we have employed that has really proven to be a benefit to people, because so often there's a gap or a restraint that is placed on where people feel like physical therapy exists, and that's because commonly we as physical therapists haven't done a good job of educating or speaking to what is potential, what is possible. We feel like our place exists only in this intermediary phase or this short-term phase, when really it doesn't. And that's one thing that we're going to speak about, because there's kind of 3 stages of care, and the model that we employ is that there's a period of time that's focused on pain relief. Then we move into another phase called the restorative phase, and that's where we work more towards the strengthening weak muscles, lengthening tight or restrictive muscles or joints, as well as working on stability and getting joints to move and work in a manner that's not going to put other joints at risk. And then you go into the long-term commitment or phase of that care, and that's the maintenance and preventative care, which we'll talk a little bit about that. And then I want you to see how preferred physical therapy can help you return to your activities pain-free, and then in the end, answer your questions about your knee pain and what treatment options exist for you. So let's go into some statistics of knee pain, because it has substantially increased over the last 20 years. Its prevalence is going up. We're seeing it more in combination with BMI, and that's a measurement of your height to weight ratio, as well as age. So we're noticing the older and heavier we are, the more knee pain we experience. And that's just a reality of what we're living with. It occurs in 20% of the population, and usually more women than men. When I read that it was 20% of the population, I kind of thought it was more. I mean, obviously in the situation I'm in, I see a lot of patients with knee pain, so I thought it maybe exists more, but it is 20% of the population. Now, when you look at it across the world population, it's quite high, but I also see it. I wonder if they tailor it down to just go 55 or older, would that increase? But the study didn't say. One of the common causes that we're going to talk about is arthritis, and the CDC has claimed that 1 in 4 Americans have arthritis of some kind. And arthritis is not a dirty word. This is not a condition or a plague that we're hoping to avoid. It's like gray hair. We're all going to get it. It just depends on where and how severe that arthritis develops. Knee arthritis, and there's types of arthritis, but the most common type is that osteoarthritis. Osteo means bone. So osteoarthritis is the most common type of arthritis. And people with a history of knee injury or surgery are more likely to develop this osteoarthritis. And in particular, they look at a meniscus surgery. We'll go over the anatomy in just a little bit, but meniscus tears or meniscus surgery puts you at a 4 times higher likelihood of developing knee OA or osteoarthritis. I got a clip here. This is an interview I did with Dr. Nate Moore. He's an orthopedic surgeon here nearby. Have a listen. Here we have an expert and authority on arthritis. Tell us, what does arthritis mean?
Well, there are several types of arthritis. Just the word arthritis means inflamed joint. That's all you're getting from that term. There's types of arthritis, and the most common, which I deal mostly with, is osteoarthritis.
Yeah.
Osteoarthritis is the type of arthritis that is due to general wear and tear on the joints. And if you think of joint, you think of the bones come together, and on the very ends of the bones where they articulate, where they move together, there's a surface of hyaline cartilage. It's a harder cartilage. It's not super soft. It's soft enough, but it provides that smooth motion that you would expect in a joint.
Yeah.
That hyaline cartilage, just like the tread on your tires, can wear thin with more and more miles that are placed on your joints. So I tell everybody, listen, if you drive your car X amount of miles and the tread is wearing thin, you start to notice maybe a little bit more friction on the road, a little bit more noise on your in your car from the tires. This is the same exact thing that you're experiencing in your joints, because it's starting to wear out. It's less smooth, and therefore it brings more friction to the joint, which brings more inflammation, and then that which brings more pain.
Yeah.
So really, osteoarthritis, as I mentioned, it's just that wearing down, normal wear and tear, to the point that you're losing some of that hyaline cartilage. So it's thinning out. There's other types like rheumatoid arthritis, psoriatic arthritis. There's an arthritis you can get from infection. There's arthritis you can get from all types of other things. Those, again, are going to lead to similar things, just joint pain based off of the inflammation level that you have in the joint. But it can also be treated somewhat similarly to how we would treat arthritis.
Excellent. I'm glad you clarified that, because simply put, arthritis is any kind of inflammation to the joint area, and in particular the joint surfaces where the two bones come together, and they, on the ends of those bones is that specialized cartilage. They call it hyaline cartilage, and it is unique. It's different than the cartilage we have in our nose or our ears, and it's specific to a very, we call almost a friction-free environment where there's very little rubbing or wear, until we come to this point where we've had that significant mileage or sufficient mileage. It can happen in an earlier age or a later age, to where now it's broken down and we're noticing things are rubbing differently or contacting differently. Perfect. So I really appreciate Dr. Moore's kind of explanation or description of what's going on, but I wanted to kind of orient you to what we're talking about here. So if you can kind of see, here's this white, let me get this on a pointer here. This is that white hyaline cartilage that he was talking about. So just by way of orientation, we're looking straight at a knee. You can see the kneecap right here, and you can know this is the right knee because the fibula is a bone that is on the outside of the lower shin bone, and it's always on the outside. So if I'm looking right at it, this is the outside, this is a right knee. We have this specified hyaline cartilage. We have these meniscus or wedge-shaped cushions, and then we have more of that specialized cartilage underneath there. And these commonly break down. And if I could flip this kneecap over like a pancake, on the back side of that kneecap, you'll see more of this hyaline or specialized cartilage. And what that, all that does is helps reduce friction and allow that knee to move, to glide, and to roll without that friction or without that pain. Now, as we develop in years and wisdom and whatnot, we can break down some of this cartilage little by little. It's very common. So whenever you hear terms like bone on bone, my knees are bone on bone, it's because, number one, they always started out bone on bone. But what happens, we say that more and more because now the cartilage is worn down. These shock absorbers have worn down, have been torn, or even had surgery, and previously they used to just remove them. Now they just will shave down and try and preserve as much of that meniscus as possible. But if you had a meniscus surgery in the 70s, 80s, even early 90s, I think the early 90s is when they stopped doing it, but 70s and 80s, definitely, they would just take out the meniscus. They just go in and take the whole thing out. Well, that exposed a lot more of this hyaline cartilage, and it would break down much faster. So then we had issues much sooner. So then they realized, okay, hold on a minute. Let's not take the whole thing out. Let's only take out little bits of it. So they've adjusted and modified their approach to it. Now, this is just the bone structure of the knee. We haven't even gotten into all the muscles and tendons that cross it. And what we haven't done is gone into how it's all connected, a sandwich, so to speak, in between our hip and our ankle, and how it plays a part, especially when we look at over here, how many muscles are involved just with the outside of the leg, and how impactful it is that these are all cared for and attended to when we start looking at the knee joint. One question that we get often is, do I need an MRI or an X-ray? Or they'll say, I can't start PT yet because I haven't had an MRI or an X-ray. And while an MRI or an X-ray can be helpful in some circumstances, very often it's not, because all it does is show us kind of through a keyhole or a peephole of what's going on at the knee joint itself. So we'll take a peek and look and see, going back to this previous slide, yeah, we might have some cartilage or some wearing down, which is totally normal. And that can be causing some of that pain, but it's not a good descriptor of what is happening above and below that knee and with these muscles as to why that wearing down has happened to the extent that it has, and if there's things that we can do to help mitigate the progression or slow down that progression. As I mentioned in the video I had with Dr. Moore, there is a rate of decline over time that happens. And any time that we can slow that down, disrupt that decline, is hugely helpful to not only pushing off aggressive forms of treatment like a knee replacement, but to also put life and ability back into that knee, in the immediate and near future. So often people think that because they're bone on bone or because they have some knee pain, that it's only going to continue to decline until they have the knee surgery. That's not true. That's not accurate. And so it is something that we look at from a total perspective of, and why a clinical assessment or movement assessment is so imperative, to see how good are these muscles and joints working in concert with each other, and is the knee pain really a symptom of something else going above or below. So we get into that a little bit. And some knee pain causes that we see, acutely, there's trauma, whether it's a fracture, a bone bruise, because of a fall or trauma, some twisting or deep knee bending, or whether it's, a significant ligament injury that existed from usually trauma. It can be spontaneous, maybe getting up or walking. They can happen what they call insidiously or spontaneously, where there's just enough of this wearing down that then a normal everyday movement was enough load to tear that ligament. That does happen. It's not as common, but it does happen. So we look at how to care for and assess those things. And then we look over here on the chronic side, these overuse type things, whether that's a tendonitis, which is an irritation of the tendon, and that can happen, if we go back to this slide, that can happen commonly here at the bottom of the kneecap. That can also happen here, but more commonly it's right over here. People say, I kneel down, it's just excruciating pain when they kneel down because of the pressure that places right here. Immense pain. Or it's the IT band syndrome. This IT band syndrome is another fun one, because we look at, here's the IT band. It's this thick band of fascia and connective tissue, and this is a little muscle that is normally understood to correlate to this big, thick band of fascia. Well, it's not just that. We actually have connections from the glute. This is the medius and minimus, a little further up, and then the glute maximus. They are big power movers of the hip and low back area, but also of our lower leg. Primary stabilizer of our trunk and core on a stable leg, and primary mover of our lower leg when our core is fixed and stable. So hugely important, especially in terms of knee health. So not to be overlooked, which is why it's so important that we do a full assessment to look and see clinically how you're moving and functionally how you're affected, so that we can prescribe and diagnose the appropriate treatment. And then of course we have the osteoarthritis, which is a natural progression of aging, but also can be amplified or accelerated because of previous injuries or surgeries. Ultimately, these two things can present very similarly in swelling around the knee joint, swelling of the knee, instability in weight bearing, so loss of balance, feeling like the leg is giving out, also popping or crunching sensations. All those things can be present with any one of these diagnoses, which is why it sometimes seems hard to identify the root cause of the issue, and why it seems like everyone has the same kind of knee pain, when just because the presentation is similar doesn't mean they have the same exact difficulty or diagnosis, and should not expect the same treatment to be effective for them. Another big key point, because I know a lot of folks who have said, yeah, my so-and-so, my sister, brother-in-law, friend, neighbor had knee pain and they did this thing and it really helped for them, but it's not helping for me. And that's where it's important to look at what's going on in your case. And so other things that contribute to knee pain, going into how hip, core, and ankle weakness, stiffness can correlate. That muscle tightness causes more compression, more this kind of compounding or compressive forces across a joint. that leads to more joint stiffness. Anytime we're dealing with joint stiffness, we're now dealing with an accelerated rate of arthritis. So joint stiffness is hugely important to identify and take care of. When we get stiff across a joint, we end up getting more weakness across above and below joints. And of course, this is cyclical. So then we have this massively irritating cycle of that decline, that degradation of the joint that we need to disrupt or break up so that we can then change our outcome. And what tends to happen is you have this kind of thing and you go to the doctor, and the doctor will give you a couple of options. Yeah, we'll get some images done. We'll get an x-ray and take a look and see what's going on, maybe an MRI. In the meantime, we'll give you some anti-inflammatory, some pain medications, or we'll do some injections. And this is all kind of on the road to knee replacement. You can kind of see this is just a model of what it would look like, but they shave off the joint surfaces of the bone and replace it with synthetic or artificial type materials. My issue with this is, while the x-ray is going to show one thing, it doesn't show how you move. It doesn't show how the muscles are either strong or weak or involved. It doesn't show you hip or ankle. It doesn't show you a lot of things of what's going on. It does show joint height. Well, they'll call it joint space. And if you can kind of see on this picture here, there's this thin dark line across the middle here. In a healthy joint, that would be a bigger gap. There'd be a bigger space between there. This is when we call the x-ray or MRI came back and said bone on bone. That's what they're describing. They're describing the fact that this space no longer exists to the capacity that it should. Here's what's funny. I've had several patients come back and say, oh, I got my x-rays of my knees. And it was weird because when the doctor said that my left knee was far worse than my right, I'm telling him I have more pain in my right knee than I have my left. And so why would it be different? And I hear this so often, and that's because just from what the severity of arthritis or severity of image does not correlate to pain. It does not correlate to your experience. And that's why we can't just assume that we're going to get all our questions answered by getting an MRI or an x-ray. There's still so much to go into what needs to be identified as to what's causing your pain and what can be done to improve your function, which is ultimately what we're after. Improve your ability to walk, to sleep comfortably, to not be irritable, to play with grandkids, do the things that we want to be able to do. Injections, we look at pain pills and injections very similarly. Both end up just being a mask. Going back to this next slide, injections and medications just end up masking the problem, kind of a figurative sweep under the rug, not in the sense of caring for your concern, because once we do get rid of some of that pain, we can do some more things. That's very true. We can sleep easier. Maybe we're not as irritable. Same thing with injections. We can kind of cover that up a bit, but it doesn't identify the root cause of what's going on and why we may have that accelerated breakdown in the first place, and what can be done to help break up that cycle of accelerated breakdown and get us into a more comfortable phase of aging and comfortable phase of function. So different types of injections exist. You get corticosteroids, which is a strong anti-inflammatory, help get rid of pain. Sometimes you have the hyaluronic acids or PRP injections. Sometimes they call it the crow's neck or Synvisc type injection, where they take the lubrication and try and increase the lubrication of the joint, which can have some temporary improvements. And that does help, again, for a short term, but still not getting to the root cause of the issue. Platelet-rich plasma injections is a way to kind of be aggressive in handling inflammation, with the hope that we'll be able to kind of hijack the body's natural healing ability and infuse it into a very specified location, which is why you'll have the protein-rich plasma injection. And that has shown to be helpful in managing that pain. But then here's the question. Here's the dilemma that we find ourselves is, while we now have sources to take care of some of that pain, what we're not doing is identifying sources to take care of the cause that is producing that pain, that is producing the situation to cause that pain. We're covering up the pain, we're taking care of that, but we're insufficient in taking care of the root cause with it. And that's where, in physical therapy, we try and preach that all the time in identifying what movement habits are we employing that are contributing to that breakdown. And then the next thing, often we'll have a surgery. There are surgical options that can be done before knee replacement. Sometimes they'll go in and scope it and clean it out. You've heard that I had my knee cleaned out, or that's a debridement where they'll go in and shave down some of the roughened areas of the knee to try and smooth it out. They'll do a partial replacement where they just go in and look at just the one side. It's usually the inside or medial aspect of the knee, and they'll go in and just replace that part of it. And then ultimately the total knee replacement are options in that surgical timetable. And so we get this question a lot: is arthritis treated? And here's another video I wanted to show you with Dr. Moore. So is it treatable? I get this all the time from patients. Well, I have arthritis, so there's nothing you can do about arthritis. What do you say to that?
I actually, that's one of the statements I say. I say, unfortunately, arthritis is bad. There's nothing you can really do to cure it short of replacement, and that's a further discussion down the road. Typically with arthritis, the only thing you can do is treat the symptoms until it becomes, bad enough. Now you can present the progression.
Yeah.
I'm sorry, you can prevent the progression of arthritis. You can slow down the rate at which your arthritis progresses. And so that's the way to do it. The way to do it is to slow it down, is to treat it symptomatically. And like we talked about earlier, some of the ways to do that is normal, healthy joint motion. Many people losing weight. I tell everybody, for every 1 pound of weight loss, it's like taking 5 pounds of weight of your joints as far as pressure is concerned.
Yeah, I've heard up to a 40% reduction, and this is for knee pain, up to a 40% reduction just in 10 pounds of weight loss.
Yep. Big deal, big deal. Now, a lot of people say, hey, doc, I've lost 20 pounds. How come my knees, they still hurt? And I say, well, the arthritis was already there. So we're not reversing the clock. We're not back time and growing new cartilage by losing weight. So what damage was done is still already done. But it is there for the joint long term, slows the progression, and improves your function and mobility.
That's perfect, because that's right in line with what I tell them too, is your arthritis is there. Nothing we can do about the presence of arthritis in your joints. But what we do next is what becomes very important. It's these changes that we want to make, not only to lifestyle, but also to make sure that we include a kind of a dose, what we call a dose of regular exercise or activity that is going to be healthy for the joint, so that we can change the curve at which that progression is declining. So that rate at which it tends to fall, we want to change it so that we can really slow it down and just draw it across a broader horizon of time, instead of sinking like a rock in the ocean. We want to be able to smooth it out. And that's what's going to help push off, severe treatments or, surgery. We'll talk about that later on, but joint replacement, that's going to, push those measures out a bit further.
Yeah, further down the road. And there, I've seen it all. I've seen patients that have progressed quickly from, moderate arthritis to severe. I've seen patients that have been able to take moderate arthritis and draw it out for years and years and years. So there's definitely, there's merit to what you're saying, what I've also said as well.
Excellent. So I hope that does help identify a bit more. So is it treatable? I get this all. Hold on a minute. There we go. Let's go to this next one. It is treatable and it is manageable. And to Dr. Moore's point, it's not reversible. We're not trying to reverse that, but what we are trying to do is change the progression and ultimately change the function that we're able to operate in while it's going on. Again, just like gray hair, we can't stop gray hair. Yeah, we can do things to change it, but ultimately it's going to progress. And arthritis is similar, but there's still so much that can be done in regards to that. And that's one, it brings up mechanical pain. So mechanical diagnoses of pain disorders, 70 to 80% of all muscles and joints are a source of mechanical pain. We call this musculoskeletal pain. And these can be treated naturally. There's no pills, there's no pokes, injections, and there's no procedures. It comes and goes. It has good days and bad days. It seems to come out of nowhere, often can be affected by the weather, and diagnosed with movement or clinical assessments, not by an MRI or an X-ray. our goal in physical therapy is to help you be active and independent, live free from painkillers, and avoid surgery. Ultimately, that's what we try and do, and we do this by employing 3 phases of care. And this is where my model of physical therapy is unique in that we do a lot of things early on to manage pain. Now, you notice I say manage, not eliminate pain. We try and manage pain to get it to a point where we can reduce the inflammation and get you in a spot where you're comfortable, but you're also comfortable in doing some of the activities. We start pain relief, and then we also start the restorative process at the same, very close to the same time. I mean, it depends on everyone's case, but very quickly we get into the restorative process to change or affect strength, mobilization, and mobility, because that's a longer phase of time, and being able to lay some groundwork in that phase is hugely important. And sadly, that's typically where physical therapy ends for a lot of folks, because they are trapped either by number of visits allowed by their insurance, or the fact that, hey, I'm feeling better, I'm done. And just like when you're taking pills or have an injection, just because the pain is gone doesn't mean that the condition is over or gone. In fact, just the opposite. It's now where we have a space exists for us to work on the things that we need to in order to put off or significantly reduce the amount of reoccurrence or episodes of that condition that we have going on. And so this typically takes a little bit longer, this phase from restorative to maintain and prevent, because this now is a lifelong commitment. And this maintain and prevent phase, this is what I call taking sips from the fountain of youth. This is where you're really going to get the bang for the buck. I mean, you've probably noticed, much like I have, where there are some people who just seem like, they're in their late 60s, early 70s, and they're doing all they're walking forever. They're healthier or stronger than I was in my 40s and 50s. Is it purely genetics? Sure, genetics can play a part to some of that, but it's not always. And there's a vast majority of people, and we look at maybe 20% of people have better genetics as far as aging. They break down slower. That could be true. 20% break down much faster. Well, there's this 60% of us that lay in the middle of having a lot of control, a lot of effect over the rate of that decline or that progression. Not that we're going to turn back the clock by any means, but preserve functionality, preserve high levels of functionality through longer periods of time is what we're hoping to do. And that's what I refer to as taking sips from the fountain of youth, because we have to go through slowly, and we go through slowly over time. So in this pain relief phase, this is usually within 4 to 6 weeks, but within 0 to 4 weeks, we're very in tune with how to do this. And we do a lot of hands-on treatment, whether that's some gentle massage, some light stretching, ice and heat, some different passive modalities, things that are non-active and non-loading for the patient, to try and minimize that pain while introducing comfortable movements. And then we get into this next phase, this restorative phase of care. And like I said, we start this usually within the first week or two, and this can go anywhere from 1 to 8 weeks. This can take a little bit of time, and this is sometimes where some people get frustrated, because we'll get some good pain relief, we see some progress early on, and then what happens is we start to commit to this longer period of time where we're seeing some changes, but they're just not happening as fast as they were before. And we sometimes get a little bit frustrated, a little bit impatient with that progress. We want a little bit more, a little bit faster. And I get it. I understand that. Trust me, I do. But at the same time, it's this period of commitment that is going to set us up for long-term success, especially as we get into this maintain and prevent, because what we're hoping to do, what we're actually trying to do during this restorative phase is develop some habit or some determination with how you're able to structure your day and commit to doing certain activities and specific activities over the long haul, so that now you have a built-in accountability group, or if you want to say, or a built-in accountability time where you're taking care of these things because of the plan that we have in place for you to see this progress and change over time. So then when you go into that maintain and prevent, which is 6 weeks to 12 months, really to forever, but there's a level of artistic liberty that exists for you as you get more comfortable and more aware of what movements are good for you, what exercises are appropriate, and how some of those things is left open for you to be creative and explore on your own over time is hugely effective and hugely important. And we're there with you for every step of those phases. Now, what can you do right now if you're having knee pain? Now, right now, if you're having knee pain, some of the best and easiest things you can do acutely is ice or heat, no more than 20 minutes of either one. Now, why one or the other? Originally, we thought ice was better for pain and heat was better for mobility. Now we're seeing it's just not quite as accurate as we thought. Right now, either one is fine. Whichever one works best for you, try. If you haven't done one, try one and see if the other one was as good as I thought or is better. We do encourage you to try one or the other and just find out which one is best for you. But no more than 20 minutes, and you can repeat those cycles every 1 to 2 hours. Compressive wraps for the knee are also helpful. They can help reduce swelling. They can help give you more of a proprioceptive sense. That's kind of where you are in space, helping to encourage muscles to activate or fire more rapidly, more productively. And then stay active. Our biggest thing with knee pain is stay active, but rest from those activities that cause pain, meaning don't go away from everything. Don't go sit and be a couch potato or lay in bed and say, oh, I'm resting. Doc says don't do anything. And to rest, what we want you to do is to find an activity that you can sustain without causing more pain. It's hugely, hugely important. If walking is bothersome, try cycling. If cycling is bothersome, try getting in a pool. Try and do something that allows you to stay active, keep your heart rate up, because anytime we elevate the heart rate, get it going, we're perfusing the body with blood. We're exchanging oxygen, and we're getting fresh oxygen and freshly oxygenated blood throughout the body that carries more healing factors, that improves and reduces healing time. And so it's under any circumstance, the more we get your heart rate up under a condition that's not causing more pain is the best. Additionally, if you have chronic kind of knee pain, that's stuff that's been going on for years. Now, Kathy, you mentioned that we had some knee injections and it helped for some time. You've had this pain for years. So here's some chronic things or things to do in a chronic case, much like what I'm hearing you speak to, is that we have to break up that pain cycle. So the injections are a great way to do that, to break that up, kind of interrupt that cycle. And now we're trying to restore some things. And like I said, hip and core are hugely helpful. Same with the ankle, especially if we're having a hard time with knee movement or knee exercises. Balance is the best thing to work all of those. It's also very functional. Now, you have to be careful with balance because you can fall. And this is an example. Here's this image is a person's got a towel down. It's folded up. That makes the surface softer and a little bit more challenging. And she's got her toe kind of tapping down to try and balance and maintain that posture or position. Now, what we can't see is, I wish I could get, kind of zoom out a little bit or pull this picture up and see the hips. Think of that hip. If it's straight across, think of it like a table or a seesaw. We don't want that hip to dip or to fall or collapse to the side that is unsupported. We want that hip to stay level. That's what's drawing on the glute musculature and causing it to engage and be focused on being a participant of this balance. If we let it drop or droop, collapse here underneath us, then we're muting that hip. That hip is no longer active, and we want to engage that. So that's one thing. Obviously, with this down on a single leg stance posture like this, we're getting a lot of ankle activation. All the muscles up and along the calf, the side, all these muscles are engaging to help stabilize the ankle. But notice some of these, especially the calf, will cross the knee as well. So hugely important to focus on that. One that we see a lot, and if you've noticed that one leg is more flexible, one knee bends easier than the other or tighter than the other, we have to get flexibility in that knee. And here's some couple of examples of exercises. So some knee bending exercise. Now, a lot of folks will think, oh, they just want to bend, get that bend back. And yes, it is important to get in and out of cars, up and down curbs or stairs. We have to be able to bend that knee. Equally important, and what we even consider more important because of the dynamics in walking pattern, is extension or straightening of the knee. We do want to get that knee straight, because when this knee right here is not straight, what happens is as we walk or contact the ground, our knee is then bent. That causes a flat foot contact instead of a heel contact. And when it's a flat foot contact, that drives more compression forces through the kneecap and into that knee joint. That breaks down that hyaline or specified cartilage faster, and we get more compressive forces going straight back or down into the knee in this position than are necessary. If we can get a knee straight, so we get heel contact as the first point of contact in a gait cycle, and our toes are up off the ground, and we get more of this roll through pattern, we can get more or a more sustained walking pattern to help you stay away from accelerating the progression of knee arthritis and degradation. So yes, knee bending is important, but also knee extension. And so this is one way to try and work what we call terminal knee extension. And that's that last few degrees of getting that little snap or a little bit of a pop or heel lift off the ground if you're laying on your back like this. So hugely important. So on a final note, before I take some questions, is knee pain can present similarly despite how the pain is, how it's coming from or where it's coming from. There are many treatment options for you to consider when you have knee pain, no matter what the origin is. And after this, the hope is that you have a bit more information to help you make a better decision about your condition and how physical therapy, particularly us preferred, can help you and should be at the forefront of your treatment options. Even if you are getting, treatment now, understanding how physical therapy plays a big part in helping you take care of that. So that you can live free from painkillers and avoid surgery to stay active and independent. And for you have joined us, we are offering a free gift. Thanks for joining us, taking time out of your day to be with us. And so we are offering a free discovery session. This is something that you can do on the phone or in person to talk about your specific case and answer your specific questions. And we can do this over the phone or in person. And over the phone, it can look like this, where I can see you, you can see me. We have a chance to kind of see your knee move a little bit and answer some questions and kind of move in that space. Primarily, we are a direct pay clinic, but we do offer to get your insurance information and have us check out, what out-of-pocket costs may exist for you depending on your plan. But that offer it is for you. I mean, it's viable, and we've had some people take advantage of that. And if nothing else, just to give them some certainty, some peace of mind of what they are doing or what does exist for them. But on that, I'll open it up for you. I'm going to stop sharing my screen now and answer some questions that you guys might have. We got a few minutes here.
I have a question.
Yeah, Kim, go ahead.
So I had lateral release surgery on both of my knees about 20 years ago, I think. And before then, and then even after then, with my left leg, when you were talking about like straightening it, like with my right leg, I can straighten it like a normal person. And my left leg, it's always just stiff. Like if you look at me standing, it just seems slightly bent all the time. And I spent years with like laying that ankle, like sitting with my leg out in front of me and laying that ankle on a foam roller to see if gravity would like pull it down. And I've been doing it for years and that leg hasn't changed. It's always slightly bent. And I was wondering if you have any feedback.
Yeah, so that can happen when that stiffness does come in. That can happen, and it is frustrating from our standpoint that a lateral release surgery would do that, because it typically is a very, very soft. It's a smaller or softer type surgery, but now they're noticing it doesn't quite do what we were hoping it to be done, and so they're not doing them as often. Which is just kind of the natural progression of medicine. It is a practice, and we're learning and getting better all the time.
Yeah.
One thing that I do recommend, I think you're on the right track with what they call a low load, long duration stretch, and that's what you're talking about. We have lots of studies to show that low loads over long durations of time can encourage that tissue to elongate, to lengthen, and give you some of that relief. What tends to happen is people will get a little aggressive with it, and they'll put it out there kind of in a similar situation like you're talking about, where they elevate the heel a little bit. Sometimes they'll just put their leg up on an ottoman unsupported and let that knee kind of sag or kind of sit unsupported. After a few minutes, it gets uncomfortable, and they'll think, oh, I can take it. I've got it. It's helping. And then what happens? Well, now we're activating and contracting muscles to share that, take away
Oh,
that load, and now we're taking away that ligamentous load. I was going to call it strain, but I don't want you to confuse strain with an injury. So it's just a continuous load over that tissue to lengthen and to soften a little bit. But what we've done is,
mm-hmm.
because we get a little bit of irritation, we now take it away by contracting the muscles, and then we inhibit that ability for it to happen.
Okay.
Because it takes 5, 10, up to 30 minutes of that position, of sustained position, to encourage that load. It takes some time. And so
Oh,
how do we find a space to manage that discomfort while maintaining that load that we need? And so
yeah.
it does take some balance and some awareness to do it to where it's almost, that discomfort's imperceptible, where it's almost like, yeah, but now I don't feel like it's even doing anything. I get that all the time. I don't think it's doing anything. And it's like, perfect. That's okay. Let's stay there, and let's see how if we can handle that for up to 30 minutes. And
Okay.
if at the end of, I even say 10 minutes, at the end of 10 minutes, because 30 minutes is kind of a long time to sit with your knee, especially an active mom like yourself.
Yeah, I have 2 kids. I don't have 30 minutes.
If we can get just to 10 minutes and say, you know what, 10 minutes, my knee feels like it's not sore or achy,
Okay.
then you did it perfect. Like, find that space where you're there without feeling like, yeah, but I want it, like it's a no pain, no gain kind of situation. I want it to feel like I'm doing something. This is
Mhm.
not one of those things. This is one of those where patience is the absolute virtue.
Okay, so should I use maybe like a towel instead of the foam roller? Like something that's not quite so high?
Yeah, it can be very subtle. I even say on an ottoman, put your leg up on an ottoman, and then just gauge how far away you are from the ottoman. So like, if the ottoman is resting at the edge of your heel, that's probably too far. Bring it in a little bit
Yeah,
closer, maybe past the ankle. Even sometimes with our folks who are like total knee surgery, they'll all have, hey, mid calf. Like, we got to bring it way up here, just bring it
yeah.
to mid calf, and that's where we'll find some of that level of comfort that we are trying to maintain.
Okay. Okay, I'll start doing that. Thank you.
Yeah, no problem. Good question.
Now, Kathy would like to know, is there a limit to the number of injections you can get for pain in one knee?
Yes, Kathy, that is a great question. And typically they say 3 within a year. Now that can vary. Every doctor is a little bit different. I would be very cautious with doctors who are aggressively dosing or aggressively using corticosteroids for the knee, because that also, I need to caveat that a bit, because it does depend on the shot. When you say shot, that can be a lot of different things, and so I'm talking about corticosteroids. So cortisone, cortisol. Um, Sometimes those injections will come with a cocktail or a mix. They'll have some anti-inflammatory agents, some fast-acting pain-relieving agents, and then some slower-acting but longer-lasting pain-relieving agents. And so those are the injections that you want to limit for 2 reasons. Number one, they've shown studies that overusing those can actually degrade cartilage and make breakdown faster. That's shown over and over and over again. But what it also does is blood sugars. That introduction of or steroid shots really affects blood sugar. So for diabetic populations, even pre-diabetic populations, is one thing that you really want to manage, because it can shoot blood sugars through the roof and then make it very difficult to manage, even for days to weeks at a time. So that there's a couple of reasons why you want to really limit corticosteroid injections. And typically 3 within a year is in the same spot all that you want. Now, I say typically because it is an expertise that's beyond what I perform. So I am not the source of information in that regard, but all the studies that I have read show that that's about the limit, and how overusing it is dangerous to the joint. Good question. I have about another minute. Any other questions that you would like to have? And then if you are interested in taking us up on the offer of a free discovery visit, we can reach out to you and do that as well. You can just let us know if you'd like to, and we can do that by the end of today. We just need a phone number, or you can call us. Our number is on all those slides, but also thanks. Shelby's going to put that in the chat. Pretty simple to do. You can also text that number. Some people like to do that, and we can text it just fine. But good. Otherwise, I can't thank you guys enough for showing up. I appreciate it. We love being able to help the public and knowing what can be done, what efforts are available to them, and just knowing it. I mean, I've had so many patients come in just feeling with such despair, like they are plagued with this knee pain. Nothing can be done. This is how it's going to be, and it's only going to get worse. And they're in this holding pattern of knee replacement, and that's just not true. It's not the narrative you should subscribe to. There are options in place. There are things you can do, and what I've seen over and over too with people is doing physical therapy, doing something, getting very intentional about what can be done for their knee, to then, if they end up needing to go the knee replacement route later on, they're in a much better place to recover from it because of how much they did on the front end. We call it prehab or prehabilitation to the surgery, because now their muscles and joints are in a much better place, especially if you're having restrictions in motion. If you are stiff in the knee already, you really want to get that to open up, because going into surgery, if you're stiff going into surgery, coming out of surgery, you're going to be stiff. And it's hard to get back. That motion is hard to get back. So going into surgery with as much mobility as possible in that knee is hugely important. So great, thank you. I really appreciate it. Any other questions, feel free to let us know. Send a text or a chat, however you'd like to. We're pretty open for how to communicate. Also email. Any email you've gotten from me, you can respond and hit reply right back, and they come right to me. So feel free to do that as well.